On behalf of Community Health Community of Practice, I welcome you to this webinar. I'm Sangeeta Bhattacharya, lead facilitator of the knowledge sharing platform and is based in India. Community Health Community of Practice is trying to engage cross-country knowledge sharing and dialogue in response to the pandemic and has undertaken several activities like a webinar discussion where 160 participants across geographies shared how countries are handling the pandemic in the community level. We have just completed a rapid evidence synthesis where learnings from previous 5 epidemics can guide towards strategies in terms of community engagement for COVID-19 prevention and control. The detailed result will be shared in our forthcoming webinar, which will be in last week of June. Today's dialogue nicely fits to our mandate of cross-country sharing of experience. We are happy that UNICEF, WHO, and IFRC will be disseminating the guidance document on community-based healthcare, including outreach and campaign in the context of the pandemic, followed by a panel discussion. On behalf of UNICEF, I invite Hannah Sara to highlight few key features of the guidance document. Hannah Sara is the community systems specialist in the health section in UNICEF headquarters. Prior to this, she was the health focal point for every woman, every child in the executive office of the UN Secretary General. Previously, she was a manager of the 1 Million Community Health Workers campaign and a country portfolio manager at WHO in Geneva. Her career in global health focuses on country health systems and strategies to overcome inequities in access to healthcare and other public goods. Hannah Sara has a MSc from LSHTM and London School of Economics. Over to you, Hannah.
Hello, Sangeeta. Thank you for the introduction. I'd like to share the overarching principle for this discussion, which is that the community-based platform, with its distinct capacities for healthcare delivery and social engagement, has a critical role to play in the response to COVID-19 and is essential to meeting people's needs, especially among the most vulnerable. This guidance outlines considerations for designing a comprehensive and coordinated approach to community-based healthcare to keep people safe, maintain continuity of essential services, and ensure effective COVID-19 response. Decisions should be aligned with relevant national and subnational policies and should be reevaluated regularly as the risk-benefit analysis for any given activity changes during the COVID-19 context. Considering overall disease burden, COVID-19 burden, and COVID-19 transmission scenario, as well as community system capacity at baseline, activities may need to be anticipated where COVID-19 transmission has not yet become active, modified where an alternative mode of delivery is safe, or temporarily suspended where risk of COVID-19 transmission is high. This document complements a range of other guidance from across our 3 institutions, including that on priority public health interventions, maintaining essential health services, facility-based care, and risk communication and community engagement, among others. The term community-based healthcare is used in this document to include services delivered by a broadly defined community health workforce, which we acknowledge varies based on country context. These are lay and professional, formal and informal, paid and unpaid, as well as the facility-based personnel who support and supervise them and who themselves may provide outreach services and campaigns. As trusted members of the community health workforce usually has strong ties with other local actors, faith leaders, and community groups. This guidance is intended for decision makers and managers at the national and subnational levels. Given that national policies and capacities for community health services vary widely, and that the COVID-19 context represents an opportunity to invest in and strengthen the resilience of the community-based platform into early recovery and beyond, the themes covered by this guidance will be adapted in varying settings, as will be illustrated by the 5 panelists joining us today. The guidance document is organized in 2 parts. Part 1 addresses basic principles and recommendations to inform decision-making for maintaining essential health services and strengthening the COVID-19 response, including key actions for community engagement focused on building trust, reducing fear, and promoting the uptake of public health measures and essential services. It also includes guidance on adapting key health systems functions, specifically to reinforce the capacity of the community health workforce and strengthen supply chains and health information systems. Recommendations on screening for COVID-19 infection and infection prevention and control measures are also included. Part 2 of the guidance addresses key considerations for specific life course stages and for disease-specific programs. These modules are not covered by the panelist presentations today, so we highly recommend that you visit the guidance document online. The guidance is currently available in English only, but will soon also be available in French, Spanish, Arabic, and Russian. And now back to Sangeeta to introduce today's panelists. Thank you.
Thanks, Hannah Sara, for the presentation. Now we will move to an interactive discussion with community health champions, which will include remarks from Ministries of Health of Gambia and Afghanistan, perspective from UNICEF in Kenya, as well as reflection from an NGO, Save the Children in DRC. And last but not the least, it is the direct voice of a community health worker from Togo. Let me now introduce you to our esteemed panelist. Dr. Roy Husseinzada is the head of community-based healthcare department in Ministry of Public Health, Afghanistan. Previously, she worked in the community health department. Her interest in public health started when she worked towards prevention of blindness program and in RMNCHN clinic. Modu Nijai from Ministry of Health Gambia will tell us how his country is dealing with COVID-19 and particularly how risk communication and engagement strategy has been adopted. Modu is the Director of Health Promotion and Education at the Ministry and is responsible for planning, education, health promotion, and risk communication at the community level. He is currently the chairperson of the Risk Communication and Community Engagement Subcommittee and coordinating the activities for the pandemic. Papa Dio from Save the Children DRC will speak about IPC experience from the country. Dr. Dio is Chief of Party leading the flagship health program Signature across DRC. This program is implemented in 12 health zones of the country. He has also served in Save the Children Senegal country office as health and nutrition specialist. The perspective and experience from Kenya will be presented by Rose Nijrani. She is community health specialist in UNICEF. She supports the national government in development of national policies, strategies, and also support countries for adaptation and contextualization. Finally, we are very happy to have Afia, a community health worker from Togo. She will share her experience in terms of service provided at community level for COVID-19. Afia is supported by Integrate Health in her work for the ministry. We are happy to listen to Afia and grateful to her on behalf of millions of CHWs who have been providing services in this pandemic. For too long, decisions about community health workers have been happening without community health workers. Now UNICEF and Community Health Community of Practice stand behind the goal of CHW Advocates campaign to demand and support the inclusion of CHW voice. So we can start the panel discussion, which will be followed by an interactive question and answer session.
Assalamu alaikum. Hello, everybody. This is Dr. Roya from Afghanistan, and it's my great pleasure that got the chance for sharing Afghanistan health system response to COVID, especially through the community-based healthcare system. In Afghanistan, community-based healthcare is part of health system. As you can see in the schema, here is health facility and the community health supervisor are working in the health facility. We have around 1,200 community health supervisors. The community health supervisor link it with other component of CBHC, which is community health worker, and the community health workers are working at the health post level. And also we have family health action groups and the community health post shura and facility health shura. Also, we have community development council, which are part of citizen charter program, and village development council, and family health houses are the other component of CBC program in Afghanistan. COVID-19 cases have rapidly raised in Afghanistan. As of 7th June 2020, the total confirmed cases are more than 20,000, and total recovered are 1,875, and total deaths are 357. And 1.65 is case fertility rate. So transmission and classification of this corona is a cluster of cases with widespread community transmission, and Kabul, the capital of our country, remains the most affected part than the other provinces like Herat, Kandahar, and Balkh. As you may know, there are many contributing factors we are facing. As prolonged conflict, political crisis, immigration, displacement crisis, frequent natural disaster, diseases outbreak, and mass population movement. Also, a stretched national health system, porous border, and people living close together with limited access to water supply, sanitation, and hygiene facility and services are contributing factors. Regarding health system response to COVID-19, we have a high-level emergency coordination committee with 5 technical working groups at national and international subnational level, and a preparedness plan with humanitarian partners and stakeholders. Also, there are awareness sessions at the health facility level, and we have developed lots of IEC material in local languages, and there are health facility distinguished for isolation and case management of COVID-19 at the national level, regional, and provinces, and the capacity of the service provider has built. Regarding the community health system to COVID-19, we clearly define the role of the community-based healthcare component, like the regarding the response of COVID-19. For example, the CBC officer, CHW trainer, CHS, and CHWs, and Family Health Action Group, Health Shura, all of them has their defined role in response to COVID. And also build the capacity of community health supervisor and community health workers for early detection and isolation, referral, and follow-up of COVID-19 cases in their catchment area. And these people are part of the population surveillance committee. Recognize and remunerate the community health workforce is very important, and in this situation, so we planned for incentivization of our CW, because they are still volunteer, but we want to start the incentivization of them from this COVID-19 response. And also we plan to distribute health phone credit card for the CHSs, because now the reporting system is more from the remote and through the phone. And also ensure community of RMNCH essential service, especially for pregnant, postpartum women, and including newborn and children. Also, the CHW or community health workforce involved in distribution of iron and folic acid for adolescent school girls, because now the school are closed. Regarding the supply chain and health information for deliveries and dispensing to avoid extensive contact inside a health facility, outdoor distribution as supply is doing there, and we distribute the supply for CHW or for health posts during any training or any gathering to avoid the additional gathering. Also, there in Afghanistan recently we established DHIs 2 and all health information data and health data is coming through this digital system. Fortunately, CBHC data also included this system. The another thing is two-way communication with the community. It's very important because for the community mobilization, the people right is to know well about the situation and about the surroundings. Recently in Afghanistan, we developed a community mobilization plan for the response of COVID-19 at community level by using the CBHC component. It's combined of awareness raising, intervention and camping, also community readiness and local business activation. So in the awareness raising and campaign, through the CBC component, about the dissemination of the reliable and context-specific information about COVID-19 information to maintain good health and challenge stigma and discrimination at community. Also for preventive practices like simple mask, physical distance, and hand washing. Nutrition, hydration, exercise, rest, stress management, hygiene, and sanitation, all these are included in this awareness campaign. And also for the people we are to get facts of COVID-19 and risk communication and protecting vulnerable older people from smoking and good ventilation, and also know the symptom of the COVID and home quarantine and caring for COVID patient at home and how and when to seek the care. All of these is included in this awareness sessions. In addition, the special concern about the funeral and burials are also another part of this awareness. The second was guidance household about the community readiness. Coordinate mass local protection of simple and appropriate clothes, face masks by all household. As you know, every year now is the shortage of masks, and now in Afghanistan, wearing mask outdoor or out of the home is now become a policy of the MOPH, and everybody should wear the mask. So the shortage of masks could be appear there in many countries. The other thing is engagement community to support the preparation for isolation sites, because people have very small houses and no facility for the quarantine and isolation. And be kind, help each other, support the isolated and the poor, and welfare things is all included in this our community mobilization plan. Also engagement community to fill the gaps staffing in the health facility. As I mentioned it, the inclusion of the CHW and CBT, CHSS and the surveillance and case finding, and engagement community and monitoring and quarantine complaint and another things. And the third part is technical intervention to activate relevant local business for response to COVID-19. It means that engage tailoring shop in the mass production of simple and appropriate cloth masks, and also engagement a stationery shop and the cushion shop for the furniture shop for the mass local protection of simple clear plastic face shield, because face shield is also important as the mask. So by this community mobilization plan, it will sustain the engagement and self-protection. Also, it will also maintain community solidarity despite understandable level of fear and uncertainty in the country. It is our plan, and we are starting to implement this plan, but we need more resources for this implementation. Our challenges in CBHC is a shortage of women workforce, especially in the the CHSS and community health supervisor. Also, women access to information and outbreak and available services is very low, and tailoring community engagement intervention for gender, language, and local is our barrier in Afghanistan or our challenges. Also, the shortage of PPE and the data and surveillance is not very verifiable or well progressed. The supervision and monitoring of CBHC services, another problem or challenge in our CBC program. Also, I think everywhere is the shortage of financial resources, especially for community-based, because now all are focusing on facility-based. Also, the Ministry of Public Health will more focus on facility-based, and primary healthcare and community-based as now face financial inadequacy. So it was all about from my side. I'm so sorry that the time was so short and 10 minutes, but lots of material there was. So I hope you can get something from this my presentation, and I'm here for your question in the panel. And thank you very much for your attention.
Good morning, good afternoon, good evening, depending on where you're dialing in from. As you've heard, my name is Rose Njeraine, and it's a pleasure for me to share experiences from Kenya in developing and implementing guidance on continuity of community health services in the context of coronavirus pandemic. I work for UNICEF Kenya Country Office, and I am based in Nairobi. So just to introduce why it's important to be able to come up with ways to select the essential services that must be provided. Doing this process helps prevent communicable diseases, including vaccine preventable diseases for children under 5. It helps the government be able to come up with specific measures to protect vulnerable populations, and it helps in managing emergency situations. The general steps on how this can be done is coming up with a list of all the community interventions that are provided, identifying the ones which are essential, and identifying those which are not essential that can be postponed or can be interrupted and then can be introduced later when the country is out of the emergency or out of the pandemic situation. Modifying the community level service delivery is also important, and in this case, it's making sure that we respond to the pandemic in terms of avoiding large gatherings. So coming up with innovative ways to continuing delivering services like using digital platforms or telemedicine. Of course, updating the registers of the vulnerable population is critical because it helps you keep a list of all the vulnerable households that must receive these essential services and whose contact is going to be maintained even during times where movement is quite restrictive, like in the cases of a lockdown. Adapting diagnosis and treatment protocols is important. If you're going to change your service level, your service delivery modality to like phone-based, you have to come up with assessments in which the community health volunteer will be able to interact with the household and be able to assess the health or the well-being of the household at the time, be able to work with the household to identify danger signs and potential situations for referral. Also be able to protect the CHVs in which they're able to implement low-touch protocol or no-touch protocol to reduce their exposure to COVID-19. So in the case of Kenya, if I may share some context, Kenya, our lowest cadre in terms of service provision at the community and household level is a community health volunteer. These volunteers are not salaries, but they're supposed to be getting incentives from their county governments. Right now, very few do, but we're working on that. They are selected by the communities that they serve, and once they are selected, the CHVs are given an 11-day basic training and then deployed. So while they are in service, then they can receive some technical trainings to further improve on their service provision. The activities provided by CHVs are usually health promotion and disease prevention activities, but some of them also provide curative activities, especially in ICCM, in the management and treatment of moderate malnutrition, malaria, diarrhea, and pneumonia in children under 5. Why did we think it was important to come up with guidance on how to continue the provision of essential health services? First, we found out that communities were fearful of going into health facilities because health facilities were perceived
Hi,
to
I
be
hope this
sources of
works.
infection. Second
Apologies
thing
for
we found out also is that health service providers themselves were feeling exposed due to the lack of PPE. And so they were fearful in interacting with large numbers of people without feeling that they were protected from COVID-19. We also find out that care-seeking behavior, especially for pregnant women, had reduced during curfew hours. Women were afraid to step out of their homes to go into the facilities to deliver because they felt like they did it during curfew, they would be arrested. And so we found a combination of all these three has led to a big reduction in the demand of essential health services. So we did come up with a few key strategies on how to make sure that essential health services continue being provided at the household level or in the community. So these were based, like the first one is a guidance for CHVs on how they can provide essential health services based on different scenarios. And in this case, if I may just create some context for Kenya, again, is that Kenya as a country, it's a very heterogeneous country. We have agrarian populations, we have people who live in the arid and the semi-arid lands, we have urban populations, and the context for each is very different. We have 47 county governments, 47 counties. Each county is a government on its own, led by a governor. So even in the case of reporting for COVID-19, as much as we are getting an overall picture of total number of cases, we are also getting a breakdown of how many number of cases in each county. So you can find yourself in scenarios where you have a county that doesn't have any case, or a county like Nairobi that is in widespread community transmission. And so as you get lower, the response of a county that doesn't have any case would be very different from the response of a county that is in community spread. And so that's what we wanted to do. We developed different scenarios for each county. The other strategy to discuss is outreaches and community-based care for COVID-19 patients. So in terms of the first one, continued community health services based on different scenarios, what we first did is come up with the essential services that we are talking about. Which services are these that must be provided, even in the case of a lockdown, even in the case where the government has said no movements? And it was a long list of essential services which we felt were important, a few of them being health education and health promotion, and in this case with a focus on COVID-19. Family planning services were also identified as critical. Care during pregnancy, of course, like in the cases of ANC, skilled delivery and postnatal. Essential newborn care, provision of services to children under 5, especially vaccination and child health, chronic illnesses, disabilities, mental health, and sexual-based violence were also considered essential services. And then from there, once we identified the services, it was able for us to identify what the priority groups were and to come up, and then we also came up with the guiding principles that would be applied across all the scenarios. So the guiding principles would change depending on the scenario that you're in. So like in the case of training, sensitization, and protection of community health volunteers. In cases of protection, a CHV that is working in a county that doesn't have any case would need protection that is very different from a CHV who's in a county that is in widespread community spread. So for example, where there's no case, is a mask, a set of gloves, some hand sanitizer, is that enough as PPE for them compared to the ones who are in community spread where they need to be protected as well as the other healthcare providers? So they are provided the full range of PPEs, including gowns. So we provided that guidance. Just to give an example of service delivery, in places where there are no cases or have sporadic cases, we are guiding CHVs to provide the regular household visits, but to do it outside. To do it outside for family only, just one family, not to put many families together, and to maintain a low-touch protocol for assessment. In places where there are cluster of cases, we are guiding the CHVs to make household visits only to priority risk groups and to conduct regular household visits by phone only, to maintain a no-touch protocol in which they work with the caregivers for them to be able to lead the caregivers into assessing various components of the health of the household. Where there's community transmission, we are asking the CHVs to make household visits by phone only. So for integrated outreaches, the outreaches are supporting in continuing to provide essential health services by the facilities going into the community. So finding a school or a church where they provide these services, and also providing in services in the context of social distancing and the implementation of IPC. The CHVs in this case, their role is in social mobilization and in crowd control, and making sure that they're able to give a movement plan for clients as they come in. And this is how the outreaches look like. Over there at the back, you'll see in blue, those are the doors in which people are coming in. The first thing you do is wash your hands. You can see a woman there and a girl in green washing their hands. And then your temperature is taken while maintaining some distance. This is how the lines look like. The lines are outside, and there is distance between the clients just to make sure that we reduce the sources of infection. All essential services are available. There are doctors on site for treatment and for sick clients, but then you also have the well check clinics. So in cases of nutrition, in cases of immunization, and all the other essential services that I had listed before. So there's also the other component, which is the home-based care for COVID-19 positive clients. And I think for us in Kenya, we are exactly where the rest of the world is, in that our positive cases are also asymptomatic or with very few signs and symptoms. We are also, as our cases are going up, we're also finding ourselves in areas where our health facilities are crowded. The guidance provides 6 specific steps for implementation of community-based or home-based care in terms of eligibility, assessing the area that is feasible for home-based care, procedures for home-based care, referral. What do you do when you're isolating yourself or you're providing care to somebody and then the person progressively starts getting worse? How do you protect yourself as a caregiver who is providing home-based care to somebody positive to COVID-19, and what are the steps of ending home-based isolation? Finally, there is also guidance on the role of CHVs in home-based care for COVID-19 clients, and we said in our case, the mandate for CHVs is within the households, and CHVs will train and raise awareness to household members on caregiving for COVID and how to handle yourselves when you're in a household that have somebody who is isolating. CHVs will provide linkage for referral. They will provide support in ending of isolation, and they will provide support in the mapping and identification of suitable isolation centers within the community. The isolation centers are critical because it's not every household in Kenya that has a separate room that allows for people to isolate themselves. So if you don't have that room, then you can go to a home-based isolation center that is near, into a community-based isolation center that is near your home. So thank you very much, and I will be willing to take questions after this. Thank you. Thank you.
Bonjour, je m'appelle Kwabafi. Je suis agent de santé communautaire de l'ONG Santé Intégrée au Togo. Je suis dans la communauté de Sarakawa, dans la préfecture de la Kosa. Ma présence portera sur le renforcement de la réponse COVID-19 dans la communauté. Renforcement de la réponse COVID-19 dans la communauté. Le personnel de santé communautaire peut être mis à contribution pour renforcer la réponse de la COVID-19 par de membres de confiance dans la communauté qui ont un lien important avec les formations sanitaires, les dirigeants et les organisations qui contribuent de manière essentielle à une réponse efficace. Ils ont pour tâche de veiller à ce que les activités communautaires soient intégrées dans les plans d'intervention nationaux. Identifier les activités clés pertinentes au contexte pour le personnel de santé communautaire, puis y contribuer. De la communauté, établir des protocoles pour le dépistage communautaire COVID-19 en utilisant des définitions de cas standardisées. Les équipements de protection individuelle. Pour les équipements de protection individuelle ou encore appelés EPI, les agents de santé communautaire sont les premiers points de contact avec la communauté. Il est donc essentiel qu'ils soient bien équipés et protégés par des équipements de protection individuelle, notamment des gants, des masques et des écrans faciaux. Ils doivent également disposer de gel hydroalcoolique pour désinfecter régulièrement les équipements de travail afin d'éviter toute contamination. L'éducation communautaire dans la communauté. L'éducation communautaire. Dans la communauté, nous devons donner l'exemple l'exemple en maintenant une distance sociale d'au moins d'1 mètre entre nous et nos patients. Nous leur expliquons également pourquoi la distance sociale est importante pour prévenir la propagation de cette maladie. En plus de cette distance sociale, il nous est maintenant impossible de rassembler beaucoup de personnes. Nous pouvons donc plus de temps à visiter les foyers et dans la communauté, à parler avec les gens et à leur donner une éducation sanitaire. Identification des cas de COVID-19. Les visites à domicile commencent désormais toujours par une séance d'information sur les mesures de prévention et les signes d'identification de la COVID-19. Cette sensibilisation se fait aussi dans les centres de santé. Cette sensibilisation se fait aussi dans les centres de santé. Par exemple, nous voyons sur la photo le RFS en train de faire la sensibilisation à l'UST. Si nous identifions un patient présentant des signes de la COVID-19, nous en informons le responsable de la formation sanitaire de la communauté pour les soins aux patients. Par exemple, j'ai croisé un enfant qui faisait la fièvre et la toux et j'ai référé l'enfant à l'USP. Le RFS a pris en charge et a identifié que c'était la toux simple et que ce n'était pas la COVID-19. Et il a pris soin, il a soigné l'enfant et il a fait retourner l'enfant dans la communauté et j'ai fait le suivi jusqu'à la guérison. Sensibilisation au lavage des mains positif, de lave-mains, sensibilisation des mains, au lavage des mains et dispositifs de lave-mains dans la maison. Un message tout aussi important dans notre éducation communautaire est l'importance de se laver régulièrement les mains. Nous encourageons l'installation des dispositifs de lave-mains dans les foyers afin que chacun puisse se laver les mains régulièrement avec de l'eau et du savon ou de la cendre. Nous sommes également à la communauté. Nous montrons également à la communauté comment fabriquer comment fabriquer des dispositifs de lave-mains traditionnels à moindre coût. On donne des conseils aux familles de disposer les dispositifs de lave-mains traditionnels devant les maisons. En fabriquant des piquets avec un bidon, on met l'eau dans le bidon et la cendre ou le savon à côté et chacun se lave les mains. Continuer à fournir des services de soins. Malgré la pandémie et les mesures respectives, nous devons continuer à fournir des soins de santé à notre communauté. Nous veillons à disposer des équipements de protection nécessaires comme mentionné précédemment, à savoir les gants, les masques et les écrans faciaux et les gels hydroalcooliques pour désinfecter les équipements de travail avant et après leur utilisation. Par exemple, l'ASE se lave les mains avant son activité et avec son cache-nez. Nous nous efforçons de poursuivre notre travail dans nos communautés et de veiller à ce que les soins de santé de qualité et les formations nécessaires et les informations nécessaires soient fournis aux membres de nos communautés pour leur bien-être. Merci beaucoup.
Good afternoon to all of you listening to this presentation. Today you have your presenter. I am Mr. Modunjai. I'm the Director of Health Promotion and Education at the Ministry of Health. And I also double as the Risk Communication and Community Engagement Committee lead under the Ministry of Health. And then this is a multi-sectoral committee. Today I'm doing a presentation on risk communication and community engagement to share our country experience on COVID-19. First of all, I will take you through, as you know, looking at the communication and community engagement. The guideline has already been presented to us, and then looking at what areas have been. The first two slides are mainly what actually is happening. So now what we are doing, community engagement, community communication and community engagement in COVID-19 within the context of the COVID-19 experience from the Gambia. First of all, I just want to share our experience, this communication as part of the community engagement for COVID-19 response. We have also been engaging district authorities. These are the chiefs who also in turn conduct step-down orientation for village heads and as well as village development committee members to strengthen community-based surveillance on the development of community action plans and also to come up with strategies and materials. This is a very cost-effective and sustainable strategy because the district authorities themselves are the ones responsible for creating awareness by engaging the various committees. We're also involved in engagement and utilization of community vigilance, community vigilantes. These are the youths from the various communities. What we did was when we did our sensitization, they were able to identify active youths that were also able to stand somewhere the position in the community at the entry point, like between the borders of the certain communities, and then they are supported by the village development committees. And these are people whereby they are from that community and they ensure that they carry out border surveillance along the borders of the Gambia and Senegal. We've also been engaging the multidisciplinary facilitation teams. The multidisciplinary facilitation teams are a diverse team from different sectors to carry out step-down orientation of village development committee members and community influential leaders in the development and implementation action plans on COVID-19 response. This is also another cost-effective strategy because if we look at the multidisciplinary facilitation teams, these are diverse members of extension workers in the various districts. We've also been engaging the Red Cross volunteers on COVID-19, which also, when we engage them, we also end up now engage them to be doing house-to-house sensitization by the volunteers at household level. So raise awareness at the level of the household in every community. So it's also something that's very sustainable and cost-effective, and then it also shows the partnership we are working. I mean, we are working with the Gambia Red Cross Society. The other area we've been doing, as you know, even within the context of COVID, we still ensure that we implement, in collaboration with partners, ongoing cost-effective child survival and development interventions or initiatives through the engagement of village support groups, parents, caregivers, and household heads in the promotion of 4+4 key household behaviors. This is a UNICEF-supported initiative, and I think we started from 4+2, now we are in the 4+4, and then the 4+4 concept is all about along the line, even within context of COVID, we're still promoting exclusive breastfeeding and also trying to ensure hand washing with soap, ORS, and also as well as ITN, so that people, all the children, especially children and under 5, and also pregnant women to sleep on the treated bed nets. Plus, this is about the first 4, and the second 4 is the prompt and early care seeking for pneumonia, also water treatment, cord care, early antenatal booking within the context of COVID-19 pandemic. We're also implementing social and behavior change communication interventions for nutrition interventions, looking at food fortification, infant and young child feeding, WASH, maternal nutrition, etc. All these activities are currently being implemented with the support of our UN partners. And this is something that is ongoing, even without COVID. But currently with COVID, we are strengthening and scaling up our intervention to ensure that people are given right and appropriate information at all times. And this is mainly at community level during the COVID. And we strict observance of social distancing. And most of our interventions are community level, because we know normally most of these community interventions, they attract a crowd. So we ensure that we all make sure that we take community to stick for strict observance of social distancing, which is something that we're always very mindful of. We also continue to coordinate our risk communication and community engagement interventions on both at national, regional, and district levels. And then we were, with the support of our UN partners, with the lead of UNICEF being the lead agency in that area, was able to work together with our committee to develop terms of reference, TOR, and this is really helping us a lot in guiding our roles and responsibilities as a risk communication and community engagement committee. There's also an existence of stronger collaboration and partnership with the media on COVID-19, which also resulted to increased media participation in COVID-19 reporting at central and regional levels. We also build the capacities of journalists who are successfully trained, that have been trained on, for example, health reporting, how to identify rumors and how to address them. And mainly we also focus our training on what is the role of the media in sensitizing the population on COVID-19, and how can the media ensure that preventive measures are fully adhered to for a successful fight against COVID-19. This is one of our most interesting activities, because what happens is, like, even the media are now even asking us, when are we going to have a similar training? And I think it's something that they really appreciated it, and that the capacities have been built in this area. We also organize women groups, organize women groups, traditional communicators, youth groups, adolescent, which are comprised of youths, adolescent, and physically challenged groups, are also actively engaged in COVID-19 RCCE activities. When you talk about COVID-19, we also thought there is a need for inclusiveness. And therefore, we have also engaged a physically challenged through the association, and we've been working with them, and then we have some activities with them. And currently, we also have somebody in our group which is also facilitating our television program using the sign language. And then I think that's also bind our relationship with this specific groups. There's also an existence of a toll-free number, which is 1025. We just provide vital information on COVID for the public around the clock. We get 24 hours around the clock, because you can see that we have a functional call center, and this call center is also helping us to track people who are coming into the country. And now, in fact, because of the strength of our community surveillance, people are using that call 1025 to report. Either people are coming in illegally, they report, or sometimes they'll be having neighbors that will come in and out, and they also have to look at their movement and report. And then in this call center, we're also able to track most of our cases that we have been taken to quarantine is as a result of usage of the 1025, which for us is one of our best practices. Other countries can learn from us, because the people have used it, and there is a big, increase awareness on the use of the 1025, and everybody knows what the 1025 is all about, and they use it to give us information on COVID. And I think it's something that we want to share our experience with other countries. There's also a comprehensive community engagement plan developed in collaboration with our district authorities for COVID-19. These district authorities, when we engage them, normally they will also develop an action plan. And this action plan, when they're implementing, either they are engaging the heads of villages, or they are engaging heads of households. We make sure that they have a plan, and they can only effectively function with a plan. And if they don't have a plan, they can effectively function. So this is something that we've also been engaged in, and it's a strength that we think other countries can also have. Because if we are able involved in engagement only alone without developing an action plan, which you can use to monitor the performance of the people you have trained, is something that is also going to help. We also have a stronger involvement of creative artists. These are the artists, they either have a song, or they are poets. And then we've also been involved in it, and they came for us to work together to create awareness. And they also produce some awareness materials, and then we were able to develop a standardized compensation criteria to be, by the RCCA. Why did we develop a standardized compensation criteria? Because if we look at some of them, we are able to produce videos, some are able to produce audio, some are poets. We're also able to look at the length of those audios and videos, and we're able to make a recommendation for them to be supported, so that next time they can also be participating in our intervention. There's also stronger participation of opinion leaders. These are the legislators, these are the National Assembly members, the religious leaders, these are either Christian or the Muslim groups. We also have local government authorities, influential women leaders. They're all interested in the fight against COVID-19 response, and I think we have seen that in our committee. There is a huge representation of women in the RCCE, which is another thing that we think other countries can learn from us. There is also successful countering of rumors and fake news on COVID-19 through different platforms, either through press releases, through interviews, or etc. And we also have a Facebook page, on the MOH Facebook page, which definitely can be used to be used normally to counter fake news and rumors. And we use also our press releases to clear the air at all times. There's also engagement of traditional healers on COVID-19. This has been strengthened. This collaboration is strengthened with the RCC committee, and also there's also with the Traditional Healers Association. There's a strong link between the RCC committee and then the TRAHA, that is the Traditional Healers Association, to ensure that they also build their capacities in that area. UNICEF and partners also develop a tool called Rapid Pro in collaboration with MOH that uses SMS technology to collect information needed for program implementation. And this is really going on fine with us, and I think we're happy, and then we're now tracking real-time information. We're also working with MRC Gambia and then to develop a COVID-19 remote tracking platform that can also help to collect information on COVID-19 from the public. It's also something that we are really using the platform, and then we're also going to move forward to put it into our DHIS2 to be able to get information on COVID-19. There's also high-level synchronized broadcast for television and radio covering all aspects of COVID-19, and it has been successfully implemented with high-level personnel for the various sectors. Engagement of area councils and market committees in the implementation of state of public emergency regulation, with emphasis on the observation of social distancing in markets, garages, lumos, temporary markets, etc. This is something that after the declaration of the public emergency regulation, we also work with the various other councils and market committees. Our committees are in the various regions, are working with this structure so that to be able to ensure that they observe the social distancing in the markets and garages and lumos are temporal markets in our context. We also conduct daily press briefings to update the media personnel and the public on COVID-19 and its related issues at all times. This is something that is also ongoing. And then this is also one of the best practices because now that there is that collaboration, close collaboration between us and the media, because every time we are together and we learn from each other, we send information through the various means. The RCC committee, through committee dialogue, mentoring and coaching, successfully broke resistance to quarantine at both urban and rural areas. At some point, we have difficulties in getting communities to be identified to be quarantined, for example. With those challenges, we are able to use our RCC techniques and strategies through mentoring and coaching, we were able to get some of those communities to accept to be quarantined. And I think this is something that people have been definitely happy with. We also increased private sector. There's also an increased private sector involvement in support of RCC activities on COVID-19. This is something that we feel is also happening at all levels. Our strategy on COVID-19 response as a country, MOH instituted mandatory quarantine of people traveling from hotspot countries for a period of 14 days. This is also something that we have instituted. We also instituted testing of people on first day of quarantine period and after completion of quarantine period. MOH also ensures periodic fumigation of all quarantine centers and homes of people facilities upon quarantine. MOH also ensures that the conduct of daily orientation meetings and press briefings at all national levels. And there's also wearing of face masks, especially when in public. It's also been encouraged by the MOH. The pictures you are seeing on the left is the Honorable Minister of Health and myself on the right at the daily press briefings to provide an update on COVID-19 for the general public in English and local languages. This is something that is a best practice. And anytime we do press briefing in English, we also make sure that we do it in local language, so that for better understanding of the public. Challenges, pregnant and lactating women at the moment are reluctant to take up monthly health services due to a fear of COVID-19. There is limited funds for the implementation of risk communication and community engagement interventions on COVID-19. And then community action plans have been developed and then by district authorities and community representatives, but funds are not yet available for implementation. There is challenges. We want to do mass testing of COVID-19 at national and community levels due to denial of the existence of the disease, stigma and discrimination of the families and communities affected by COVID-19. This also is really affecting us. The issue of stigma and discrimination is a big challenge. There are slow adherence to the state of public emergency regulation for the practice of social distancing. It's also something that is a big challenge for us. And we've also been, a day before the Eid celebration, because which has been an issue here, as a result of social distancing, we are also able to engage the head of the Supreme Islamic Council and as well as the Imam Ratib of Banjul to talk to the public about social distancing and how to maintain it. We also been engaging district chiefs. The risk communication team have been going around meeting the village district authorities and as well as the governors, regional governors. Youth engagement on COVID-19 is something that we want other countries to learn. We are very happy that the youth are very much engaged in it, and we use them through our 1025 vehicle to go around to sensitize the public. Again, the regional governor of Upper River region on the left and myself on the right during the engagement of district chiefs, key influencers, and women leaders on COVID-19. We think other countries can learn from. And then we also did community outreach programs to implement artistic activities, mainly demonstration of hand washing with soap at household, at community level, and then especially in the compounds of people who are visited, and then also do house-to-house sensitization on COVID-19 by the youth. So you can see the high level of youth participation in COVID-19. Thank you very much for your kind attention.
Thank you very much for the opportunity you give me to participate in this important panel talking about community health services. Slide. Based on evaluable evidence, COVID-19 is transmitted between people through close contact and droplet. Preventive and mitigation measures are therefore key to ensure the health and well-being of community health workers in the community. It is therefore important to follow recommended best practices in the prevent and control of COVID-19. It is important as well that community health workers be included in projections for COVID-19 personal protective equipment and are appropriately trained and supported in the use of PPE. The need for and type of PPE recommended may vary by region, community, and the level of transmission. Also, it is strongly recommended that all communities be adequately prepared with sufficient PPE. Global availability of PPE is highly limited at present. CHWs will likely have less access to PPE, and as a result, community health workers may be more reluctant to provide services. The Ministry of Health and partners have to be proactively to anticipate this concern and strategize response, empowering and enabling community health workers to continue service provision. About screening, for people whose screening is negative, the healthcare visit can continue. No mask is required if a distance of at least 1 meter can be maintained and there is no direct contact. People whose screening is positive are considered suspect COVID-19 cases, and the local system for isolation and management must be activated according to national protocols. WHO recommends that all people who suspected or confirmed COVID-19 infection should be isolated and cared for in a healthcare facility or dedicated community isolation facility. Where isolation in a facility is not feasible, people with no symptom or mild symptom can be managed at home as long as there is strict adherence to IPC measures and precaution and advice is given when to seek care. This situation might apply, for example, when it is not feasible to separate young children from their caregivers. Other, slide. Adhere to infection prevention and control measures established by local and national authorities and guided by local epidemiology and transmission. It may not be advisable to implement a no-touch policy at national scale if COVID-19 transmission is limited to certain regions in the country. We must enable community health workers to communicate EPC measures to community members to reduce fear and stigmatizations. Avoid inactivities that attract crowds. Adapt to community-based services to ensure spatial distancing among clients, minimum 2 meters. If community health workers conduct household visits or provide services in our own house, it is advisable that community health workers identify a well-ventilated location outdoor for the consultation instead of entering the house, and that they are provided with clear instruction and on infection control. In scenarios where lockdown are ordered, community health workers might be among those people that continue to be able to access community members. Before, during, and after each consultation, the community health worker should practice frequent and appropriate hand washing with soap and clean water and use hand sanitizer if available and there is no soap or water. Sanitation of services and equipment, thermometer, respiratory timer, milk tape with alcohol or soap and water. If available, consider handing out milk tapes to caregivers, families, and instruct them in using them. 3H. Screening of children, no direct contact. In the absence of PPE, maintain spatial distance of at least 2 meters to each both caregiver and child for symptoms. Physical examination and performance of tests such as malaria rapid diagnostic tests air duties require PPE. At a minimum gloves, ideally gloves and mask, and if available, a medical mask. Consult WHO guidance on the indication for use of masks to inform the decision. In the absence of PPE, consider a no-touch policy. At minimum of 1 meter, ideally 2 meter distance that focus on story of symptom and clinical observation of the sick child may be considered. Depending on the local context, certain tests routinely conducted by civil may be shifted to the caregivers with supervision and guidance from the community health workers to minimize direct contact with sick patients. Community health workers are at increased risk of COVID-19, therefore transmission to community members, which is important in this consideration of IPP measures. Slide. Meet ongoing population health need and mitigate the negative impacts of the COVID-19 outbreak, we have trained the community health workers to ensure that their capacity for preventing morbidity and mortality, so the community-based delivery of essential services are increased, including preventing communicable disease through delivery of vaccines, chemo prevention, vector control, and treatment. Avoid acute exacerbations and treatment failures by maintaining established treatment regimens for people living with chronic conditions, taking specific measures to protect vulnerable population, including pregnant and lactating women, young children, and all other adults. Managing emergency conditions that require time-sensitive intervention and maintaining functioning regular system, national and subnational process for identifying essential service, coordinating with COVID-19 response planning and optimizing the healthcare workforce and service delivery have incorporated relevant community-based activities and includes consultation with relevant community health workforce representatives. Slide. Slide. Uh, just to share some experience from Save the Children, we work closely with the Ministry of Health in the target areas to ensure that health facilities reach and maintain an adequate level of preparedness and response capacity for COVID-19 outbreak. We help to improve the APC measures in 64 supported health facilities based on the DRC Ministry of Health IPC Toolkit guidance. We as well provide APC wash infrastructure and supplies to health facility in communities. We set up triage and isolation areas for screening of suspected COVID-19 and other infectious disease to mitigate nosocomial illness transmission. We as well provide healthcare workers with appropriate PPE and train them on proper usage. Trainings have incorporated social distancing measures such as remote refresher training through online platform. We have a focal point per health facility who is appointed and supported to oversee APC measures. We provide supportive supervision to the focal point and support the health facility completing APC scorecard to track progress and adherence to protocols. We continue to train 320 health staff on Ministry Health COVID-19 case definition for rapid identification and establish a referral pathway based on agreed protocol. We set up community surveillance teams within the areas served by the target health facilities and build the capacity of 320 community health workers on COVID-19 to scale up the detection, prevention, and early management of case through referral linkage to testing and treatment services. We ensure that the hospitalized patients are appropriately monitored, cared for, isolated, and referred in a community home care settings. Community health workers also are trained on strategy of shielding vulnerable groups. And the last point is about how information we give to make good family health decisions and protect themselves from COVID-19. Save the Children is already active in the target community and can quickly identify youth, religious, business, and civil leaders who are trusted interlocutors in these communities. Leaders are trained in small group on COVID-19 transmission prevention measures and other approved messages. Slide. During the training, we lay out the training room respecting physical distance to prevent risk of contamination with COVID-19 trainings of agents. We have working session in community members in the way to do door-to-door visit in the context of Ebola virus disease and COVID-19 prevention. We increase as well the community awareness in the health areas supported by the project. And the last experience I want to share is the participatory learning and action men's and women's group. By creating and strengthening women's and men's group to identify and prioritize issues, plan, take, monitor, and evaluate their action challenging discriminatory norm and promoting gender equitable approaches, we support the community to create transformative social and behavior change. The design helps to maintain fidelity to the originality planned women's and men's group. but instead following a do no harm policy. The content is delivered through an interactive radio program, 25 episodes focusing on COVID-19, pneumonia, malnutrition, diarrhea, and malaria. 25 households are clustered around one community health workers who facilitate a radio listening group at village levels. The community health workers engage with each household via an initial phone call to encourage them to listen. Each week, the community health workers then carry out a weekly follow-up phone call with household members, checking their understanding of the radio program content and helping them to prioritize key preventive and care-seeking behavior to improve child and family health. The community health worker monitor and track progress on behavior pledge and implement for each household, recording these into a monitoring tool. Last slide is the fragile health system. Last slide is about, just want to come around the fragile health system in DRC, who has been further compromised due to conflict and lack of public investment and stretched by response to displacement, cholera, measles, and Ebola. This is a critical lack of health workers for a population of around 81 million people. Community health workers therefore play a pivotal role in providing health education messages and linking the communities to available health services. One of the most important and effective interventions in a public health response to any event is to proactively communicate with on what is now, what is unknown, and what is being done to get more information, with the objective of saving lives and minimizing adverse consequences. Risk communication and community engagement help prevent infodemic. That means an excessive amount of information about problems that makes it difficult to identify a solution, build trust in the response, and increase the probability that health advice will be followed. It minimizes and manages rumor and misunderstanding that undermine response and may lead to further disease spread. Regular and proactive communication and engagement with the public and at-risk population can help alleviate confusion and avoid misunderstandings. People have the right to be informed about and understand the health risk that they and their loved ones face. The perception of risk among affected population often differs from that of experts and authorities. Effective risk communication and community engagement can help bridge that gap by determining what people know, how they feel, and what they do in response to disease outbreak, as well as what they ought to know and do to bring the outbreak under control. Effective risk communication engagement helps transform and deliver complex scientific knowledge so that it is understood by, accessible to, and trusted by population and communities. Thank you very much. That's that is my presentation. I want just to share with you. I thank you very much. Thank you.
Thanks to all our panelists for your perspective and giving us an insight how countries are managing the pandemic. It is surely a great learning. We are not stopping here. We will continue this dialogue over the next few months, and we will publish this discussion in a blog, and we will try to answer some of the unanswered questions, and also keep posting your experience in the community health community of practice. So whoever is today present in our webinar, who are not member of this platform, I will urge you to please be a member and be part of this dialogue and discussion. Also, there is an interesting consultation going. You can check the link where you can share your experience, the country level experience, how community, how government are managing the pandemic in your country, because we don't want to lose all the learning that is emerging from various countries. So kindly participate in this consultation, and we will stay engaged, stay together, in the next few months till we get over this pandemic altogether. So thanks again for all your time and attention.